hemorrhoids, and as she often has an increase in thirst and appetite. Another familiar sign of pregnancy is the frequency of urination. Starting in the first trimester, the growing uterus exerts pressure on the bladder, decreasing bladder capacity and resulting in increased frequency of urination. This becomes more pronounced in the third trimester due to the size of the fetus. Be aware that the urinary stasis makes a pregnant client more prone to urinary tract infections. It is also common for the thyroid gland to enlarge during pregnancy, contributing to the typical 25% increase in basal metabolic rate. Also along the lines of endocrine changes, the pancreas produces additional insulin in the second and third trimester. If it is not enough to move sufficient glucose into the cells for energy production, however, gestational diabetes develops. The placenta plays a major role throughout pregnancy, contributing the metabolic, endocrine, and transport functions necessary for fetal support. Besides exchanging nutrients and waste, the placenta produces progesterone, estrogen, HCG, and human placental lactogen, plus glycogen, cholesterol, and fatty acids for fetal use. Progesterone helps prevent uterine contractions and also helps develop acini and lobules of the breast in preparation for lactation. Estrogen stimulates uterine development, thus providing a suitable environment for a growing fetus. Estrogen also helps develop the ductal system of the breast in preparation for lactation. Prolactin and oxytocin are responsible for the initial lactation and milk ejection. Now let's review the process of embryonic and fetal development. We'll do this by highlighting the developmental milestones and key landmarks of the gestational period. The first 8 weeks of pregnancy comprise the embryonic stage, when fetal tissue differentiates into essential organs. By the 4th week, the heart appears as a single tube and begins to beat. Legs and arms are distinguishable by 5 weeks. And by 6 weeks, the lungs begin to develop. During the 7th week, the gastrointestinal and genitourinary tracts form. By the end of the 8th week of pregnancy, the circulatory system through the umbilical cord is well established and all organs are formed. Be aware that major organ development in the embryonic stage makes the fetus vulnerable to teratogenic effects. It is important that the pregnant woman understand the importance of proper nutrition and avoiding potentially harmful substances, such as caffeine, alcohol, and drugs, including over-the-counter drugs. By the end of the 8th week, the embryo graduates to the fetal stage of development. By 12 weeks, the face is well developed. Tooth buds appear. The kidneys are producing urine. Well-differentiated genitals appear, and the fetus can make a tiny fist. At the halfway point, or 20 weeks, the fetus has fine scalp hair, and lanugo covers the entire body. The fetus begins to store deposits of brown fat, has well-developed muscles, and meconium has formed in the upper intestines. At 24 weeks, the alveoli of the lungs are forming and surfactant is present. Adipose tissue begins to accumulate at 28 weeks. Nails appear, and the eyes open and close. At 30 weeks, the fetus responds to sounds outside the mother's body. By 35 weeks, the fetus can grasp firmly, and if born at this time, has a good chance of survival, sometimes assisted with some special care measures. By 38 weeks, the fetus is considered full term, with minimal vernix and lanugo, a plump body and extremities, and good skin turgor. Okay, let's now focus briefly on assessing your pregnant client. You'll expect fundal height to be consistent with gestational age. Using McDonald's method of fundal height measurement, you'll first make sure your client empties her bladder, and then you'll place one end of a flexible tape measure at the symphysis pubis and the other on the fundus, the top of the uterus. Record the measurement in centimeters. The number should roughly correspond to gestational age, but may vary by as much as 4 weeks depending on maternal factors. During pregnancy, fetal well-being is tested by laboratory analysis of amniotic fluid, obtained by amniocentesis. It is an invasive procedure requiring informed consent signed by the client and witnessed appropriately. Under a strict sterile technique, a sample of amniotic fluid, which contains fetal cells, is taken via needle injected into the abdomen to the fetal amniotic sac. The procedure is guided by ultrasonography to prevent injury to the fetus, placenta, and umbilical cord. Inform your client that the complication rate is low, less than 1%, but includes maternal and fetal hemorrhage, infection, injury from the needle, rupture of membranes, and preterm labor. Amniocentesis is most often done between 15 and 17 weeks gestation, primarily to rule out congenital anomalies, genetic defects, and intrauterine growth retardation. Amniocentesis is sometimes done late in pregnancy to evaluate fetal lung maturity. Indications for amniocentesis include maternal age over 35 years, a previous child with chromosomal abnormalities, a parent with chromosomal abnormalities, a family history of neural tube defects, fetal abnormalities seen on ultrasound, a diagnosis of fetal hemolytic disease, an X-linked chromosomal disorder, the need to evaluate fetal pulmonary maturity, and abnormal levels of maternal serum alpha-fetoprotein, with elevated levels indicating neural tube defects and low levels indicating Down syndrome. The most widely used method of determining fetal lung maturity is evaluating the lecithin to sphingomyelin ratio. A result of 2:1 indicates pulmonary maturity. Finding a specific substance called phosphatidylglycerol in the amniotic fluid is another sign of fetal lung maturity. Prior to the amniocentesis, you will educate your client about the procedure and answer any of her questions. If the procedure is done early in the pregnancy, the client's bladder should be full to elevate the uterus and make it easier to identify amniotic fluid pocket to access for fluid withdrawal. If it is the second half of the client's pregnancy, you would ask her to empty her bladder to avoid mistaking the bladder for the amniotic sac. During the procedure, position your client with a left lateral tilt to avoid hypotension. Provide emotional support during the procedure, and if appropriate, genetic counseling referrals. If your client is Rh negative, administer RhoGAM post-procedure as prescribed because of the possibility of maternal Rh isoimmunization.